Good evening, class. This is Professor Anderson. Professor Garcia had asked me to go over this last PowerPoint that we weren't able to review in class together this morning. And so this one is going to be focused on cardiac valve issues. And we're going to be looking at the pathophysiology and the nursing process and interventions related to each of these cardiac valve issues. We're going to look specifically at mitral stenosis, mitral regurgitation or insufficiency, mitral valve prolapse, aortic stenosis, and aortic regurgitation or insufficiency. So with mitral stenosis, the main thing to remember is that this is a disorder in which that mitral valve doesn't fully open, which ends up resulting in a restricted blood flow. The mitral valve, as you can see on the image on the left, is the valve that is the opening between the left atrium and the left ventricle. When the mitral valve opens, it allows blood flow from the left atrium to the left ventricle, and it closes when the left ventricle contracts or pumps blood into the aorta. This disorder, what happens is these valves become thick or stiff, and the valve openings end up becoming narrowed, and they don't open all the way. Sometimes the stiffened valves also fails to close completely, and then we can end up having the mitral regurgitation, which we'll talk about shortly. When we have this narrowing of these valves, this results in an increase in atrial pressure. And you'll start with left atrial pressure, so you'll have pressure up in the left atrium. Then your left atrium will dilate due to this pressure. That it's kind of a cascade effect. Then you'll have the pulmonary artery pressure, which will dilate, and the right ventricle will end up results in hypertrophy or enlargement as well. What results because of this left-sided issue is you'll have pulmonary congestion with all this backup of fluid and inadequate emptying of the atrium and the ventricles. You'll have pulmonary congestion, and it will result in right-sided heart failure will occur first, and which will ultimately lead to a decrease in cardiac output. As the valve orifice narrows and the pressure in the lungs increases, the patient's going to experience, as we talked a little bit about today, a lot of different respiratory issues. They're going to have shortness of breath upon exertion. They're going to have paroxysmal nocturnal dyspnea. They'll also have a sudden onset of, which is another term for sudden onset of shortness of breath at night. They'll have shortness of breath when laying flat. They won't be able to lay flat at all, or orthopnea. And they'll have palpitations and a dry cough. So those are all some of the classic signs and symptoms as well of mitral stenosis. Some of the causes of it, which you can see, again, a picture of the mitral valve stenosis or that narrowing of those valves, is rheumatic fever. This it's not very common anymore in the United States, but it does still occur in some of the other underdeveloped countries. But it can, this is the primary cause, which causes that valve thickness through fibrosis and calcifications. As stated, we'll see this more in developed nations. Sometimes children will be born with this anomaly, and that's where a majority of the mitral stenosis incidents occur. On the nursing end, what you guys would want to look for and what we look for as nurses, again, a lot of the focus is on the respiratory issues. They're going to have fatigue. They're going to have shortness of breath on exertion. These patients will have shortness of breath when laying flat. They'll have a sudden onset of shortness of breath at night. They'll have hemoptysis. They'll have an enlarged liver or hepatomegaly. You'll see that neck vein distension, which again, what we had talked about earlier today is you want to make sure you're checking that at least a 45-degree angle. They'll have pitting edema, and you'll actually you'll see it cardiac arrhythmia of AFib. Please take a minute too to also listen to the apical diastolic murmur, which is common with mitral stenosis. Follow the link below to listen to that and familiarize yourself with that. The treatment that you'll do on a nursing end is first you want to begin with diuretics and beta blockers or calcium channel blockers. Diuretics, which will help increase that urine production. It's also going to reduce that blood pressure in the lungs by reducing the overall blood volume. You can use beta blockers or digoxin or calcium channel blockers, which will help slow that abnormal rate that can be seen with the AFib, and also helps reduce that workload on the heart. If they are an AFib, remember that you will most likely be giving some type of anticoagulant to prevent any blood clots because of that atria quivering. One of the procedures that can be done for treatment of mitral stenosis is balloon valvotomy. And what they do is they advance a catheter right where the valve opens and closes, and then they inflate a balloon which separates the valve cuffs. It almost breaks them open again. You can also do a full-blown heart surgery if you had to go in to separate those fused cusps. And kind of the worst case scenario, if neither of those interventions worked, is they could go in, do an open heart surgery, and actually replace the valve, is the other option that we have. But you can see here on the left the balloon valvotomy and the procedure that they do to repair that. Here's a picture on the left that you can see the normal mitral valve, and then on the right you can see that narrowing. You can see the smaller openings on the valve there that's not allowing the amount of adequate amount of blood to go through. So the priority nursing actions that you want to keep in mind is you want to support oxygenation. They're going to have a lot of, as we shared, difficulty with shortness of breath, unable to catch their breath on exertion and just at rest. You're going to look for and treat for signs of heart failure, which we talked a little bit about earlier today. You want to make sure that you establish a patent IV for diuretic and beta blocker medications if that's in one of the priorities. You're going to notice as well, you want to keep in mind when you're doing your assessment that the peripheral pulses are going to be maybe irregular, and faint. Remember, this patient's most likely an AFib. So you want to check your monitor. You'd want to do an EKG. If the patient is an AFib, and this could be an early sign of decompensation. So you want to make sure you notify the physician immediately, especially if the AFib is a new onset. And then again, take a moment to listen to this rumbling apical diastolic murmur that you can hear on auscultation, which is another sign of mitral valve stenosis. The next cardiac valve issue is mitral regurgitation or insufficiency. So you can see there on the left the mitral valve. And what you have with mitral, with any type of regurgitation, is basically it's a condition in which the heart valves don't close tightly enough, which allows blood to flow backward into your heart. So instead of the left atrium being able to push all the blood out, it pushes the blood out, but then the mitral valve doesn't close completely, and some of that blood flows backwards or back into the atrium. The result of this is blood can't be moved through the heart or the rest of the body as efficiently, making you feel tired or out of breath. You're not ejecting the full amount of blood that should be going out from the left ventricle into the rest of the body. So during diastole, the regurgitant output again flows from the left atrium to the left ventricle along with normal blood flow. What happens is this increased volume must be ejected during the next systole. So instead of it having just its normal amount of blood that it should eject out, it's got the normal amount of blood from the left atrium plus whatever is flowed back in. There's always going to be a little bit extra. And so to compensate for the increased volume and pressure, the left atrium and the ventricle end up dilating, and they become enlarged as well. And there's a short YouTube clip you can look at as well to get a better understanding with the mitral regurgitation. Some of the causes for mitral regurgitation are the the primary cause is degenerative due to aging and infective endocarditis. Infective endocarditis is it's an infection of the inner surface of the heart from bacteria that enters the bloodstream, and then that bacteria actually settles in the heart lining, and it usually primarily affects the valves of the heart. You can have papillary muscle dysfunction, a rupture resulting from ischemia heart disease or congenital anomalies. Again, you see that rheumatic heart disease or rheumatic fever, and this is commonly affects more women than men actually. So again, on the right there, you can see a picture of the regurgitation, the arrows going back of some of the blood flow that doesn't all settle in the left ventricle, and then the left ventricle having to do even more work by pushing a higher volume of blood out. What you want to look for as a nurse is this progresses slowly. From the last slide, it said that this comes with age. So this commonly isn't seen in the younger population. So patients may be asymptomatic for quite some time, even if they have it. When it does actually progress, what you'll see are, again, the fatigue and chronic weakness. You'll have that shortness of breath on exertion. You'll have the shortness of breath laying down, the orthopnea. You might have patients complain of anxiety. They might have some atypical chest pain. They could have palpitations. They may still actually present with a normal blood pressure. Again, you want to monitor for AFib, EKG changes, also changes in respiratory status that are consistent with the heart failure. When heart failure progresses, you're going to see the jugular vein distension. You're going to see the enlarged liver, and you'll have the pitting edema with that fluid sitting there. You'll also have a high-pitched murmur at the apex and an S3 sound as well. Our next cardiac valve issue is the mitral valve prolapse. And with the mitral valve prolapse, this occurs when the leaflets of the mitral valve, they bulge or they prolapse into the heart's left upper chamber. So instead of moving down, it opens up kind of like a parachute during the heart's contraction. This mitral valve prolapse can sometimes lead to blood leaking backward into the left atrium. So somebody with mitral valve prolapse could most likely also have mitral regurgitation as well, mitral valve regurgitation. In most people, this prolapse isn't life-threatening, and it doesn't even require any sort of treatment or changes in lifestyle. But there are cases when it does require treatment. Sorry, let me get to the next slide here. So some of the different causes of mitral valve prolapse, there's a few different ones, and a lot of these syndromes and names here, that they're just other terms for mitral valve prolapse. But Marfan syndrome, that is a genetic disorder that affects the body's connective tissue, and it's in this syndrome, the gene in our body that tells the body how to make fibrillin 1, which is a protein. It's not this gene isn't working properly, and this primarily affects heart valves. Barlow's syndrome is really just another name. It's the leaflets of the mitral valve bulge into the left atrium of the heart as the valve closes. So it's just another name for mitral valve prolapse. Again, the floppy valve syndrome, which is another cause, is, again, it's just an improper closure of the mitral valve, and that's another name for mitral regurgitation, mitral valve regurgitation. With the billowing mitral valve syndrome, again, that's just an AKA. It's also known as mitral valve prolapse. And this can be either the mitral valve, either one or both of the cusps of the mitral valve, which will bulge down. And this, again, occurs during ventricular systole. And then the myoclonus mitral valve disease. This is a common form of the valvular heart disease that's characterized by valve thickness. So the actual valves themselves will become thickened, and you'll have that prolapse. And you might even have the leaflets might be very flail or weak. Okay, next slide here. So what to look for? Again, very similar to some of our other cardiac valve issues. You'll have an irregular heartbeat, a racing, or you might have that palpitations, dysrhythmia. You'll have that dizziness or lightheadedness or syncope. You could also have the difficulty breathing or shortness of breath, again, when lying flat or during any sort of exertion or physical activity. You'll have the generalized fatigue and weakness. You'll have the chest pain. It could be a sharp pain localized to the left side of the chest. You'll want to closely monitor for any atrial or ventricular dysrhythmias. Again, we talked in depth more about the ventricular dysrhythmias earlier today. You want to make sure you're very mindful of those. You might have a mid-diastolic click and a late systolic murmur that could be heard at the apex of the heart. And the last one that we'll talk about here is aortic stenosis. So this is actually the most common cardiac valve dysfunction that's seen in the United States. And again, this is another one that's often seen or a result of just wear and tear of the heart. Aortic valve, with the stenosis, just like mitral valve stenosis, you have a narrowing and obstruction of the left ventricular outflow during systole. So you have it, again, with anytime you have this narrowing or you have a resistance with the flow, you're going to have an increase in the pressures. When the pressure increases, you're going to end up having ventricular hypertrophy. As the stenosis worsens, the cardiac output becomes fixed and cannot meet the body's demands during exertion. So, you'll have left-sided heart failure first and then eventually right-sided. If the surface area of the valve becomes 1 centimeter or less, surgery is indicated. So you can see bicuspid aortic, over on the left here, bicuspid aortic valve stenosis, which is a congenital defect. So you can see these two leaflets here are fused together. Here you've got the tricuspid valve stenosis, so you have these narrowings. On the next slide here, you'll see what it should look like. Let's go down here to the next slide. So let me just show you this real quick. Over on the right here, you can see on the top what a normal aortic valve should look like. When it's opened, you can see it's wide open, free flow. When it's closed, you have the three leaflets, kind of looks like a Y, and you have complete closure. With aortic valve stenosis, now you've got open. When it is open, it's very narrow, about not even half the amount of opening that you have up above here. And when it's closed, you can see it's not closing all the way. So you're going to end up most likely having some aortic regurgitation, which we'll talk about next. So with the causes, it's congenital, present from birth. You could have bicuspid or uncuspid aortic valves are the primary cause. And you remember the aortic valve is the one that has 3 leaflets, where the other ones have 2. You could have the rheumatic aortic stenosis. You could also have the arteriosclerosis, or the plaque or the thickening, narrowing of the arteries, and degenerative calcifications of the aortic valve. And again, that's just, with the wear and tear, that's major cause in older adults. Okay, what we want to look for, classic signs of aortic stenosis come from a fixed cardiac output. So remember, the cardiac output is the amount of blood that's pumped by the heart per minute. So when they refer to a fixed cardiac output, that's just indicating that the cardiac output, whatever it is, it's not fluctuating. So when they say you have syncope occurring during exertion, naturally, if you were, physically exercising, doing anything, working out, exercise, something like that, your cardiac output would most likely go up. Your heart's working harder to pump as you're exercising and using your muscles. On a fixed cardiac output, it won't go up. It stays the same. Which results in this syncope during exertion or shortness of breath or chest pain. Last signs can also include increased fatigue or marked fatigue, debilitation. You'll have peripheral cyanosis, and you'll have that narrowed pulse pressure. You can go on, there's a link that Professor Garcia has included. You'll have a diamond-shaped systolic crescendo and decrescendo murmur. This is just take a minute if you want just to kind of listen to that and see if you can tell a difference. Aortic regurgitation. Just like the other valve regurgitations we've talked about, is a condition that occurs when the heart's aortic valve doesn't close tightly. So with the regurgitation in the aortic valve, it allows some of the blood that was pumped out of the heart's main pumping chamber, the left ventricle, to leak back into it. So instead of going up through the aorta after it's pumped out into the rest of your body, it leaks back down into the left ventricle. So what happens here, just like in the other regurgitations, is the leakage may prevent your heart from efficiently pumping blood to the rest of the body. And as a result, your person may feel fatigued and short of breath. This is similar to the other regurgitations is in that it can develop either suddenly or over decades. Once it becomes severe enough, surgery is usually the treatment option choice that you want to use. Some of the causes of aortic regurgitation, it can be congenital, age-related changes to the heart. You could have endocarditis, the rheumatic fever, other rare conditions or conditions that can enlarge the aorta and aortic valve and lead to regurgitation. You can have Marfan syndrome, which is a connective tissue disease. Some autoimmune conditions like lupus can also lead to aortic valve regurgitation, and trauma. Damage to the aorta near the site of the aortic valve, such as damage from injury to your chest or from a tear in the aorta. This can also cause backward flow of blood through the valve. What you want to look for with aortic regurgitation is the fatigue and weakness, especially when you increase the activity level. Again, with that fixed cardiac output, the paroxysmal nocturnal dyspnea, the shortness of breath with exercise or when you lie down, the swollen ankles and feet, chest pain, discomfort or tightness often increasing during exercise, the lightheadedness or fainting. You could have an irregular pulse, a heart murmur, and sensations of a rapid fluttering heartbeat or palpitations, especially when lying on the right side. So these different cardiac valve issues, the regurgitation, the stenosis, these are all found in your IGGI book. And if you have any questions or concerns, feel free to email myself or Professor Garcia. All right, thanks so much. I'll see you guys next week.